Thank you so much for the very kind introduction. So my talk is Calcific modification strategy, and this is my disclosure. So why calcium matters? First of all, because it's very common. Today it's 100%, but normally it's 20 to 30% of the contemporary patients who undergo invasive coronary angiography and need some kind of debulking. And also because it has an impact on the procedural success, on the prognosis of our patients, because of course, as you may understand, it leads to stent under expansion, it leads to some complications such as dissections, perforations, and ultimately higher rates of target lesion revascularization and MACE. This is how the calcification will look like. The same patient, actually these are arterial artery in the limbs, but I think these are nice illustrations of the deep calcium that you may see sometimes, OFDI on the left, IVUS on the right. And you see on the OFDI that this calcification is circumferential and it's deep in the media. And at IVUS, the same patient will look like a patient with high echoic signal and strong acoustic shadows. Of course, you may have also superficial calcium that we typically call intimal or luminal calcium. Here you have a calcification with a clear border, in this picture particularly on the luminal side, and at IVUS this will look like an high echoic signal with a strong acoustic shadow. One of the particular types of intimal calcification is the calcified nodule. At the OFDI, in this case, you see an irregular protruded mass with an attenuation signal in contact with this large bulky calcification. At IVUS, it's more complex to see, but essentially it's again a protrusion and an irregular mass with a high acoustic shadow. So IVUS and OCT, of course, intracoronary imaging techniques are very useful to detect calcification, but we do not have to forget, of course, CCTA and invasive coronary angiography itself, particularly for the global assessment of calcium in our patients. And of course, CCTA does less well in terms of volume calcification, quantification, as well as in the quantification of the calcium arc, the calcium thickness, and the longitudinal length. This is something you do much better with intracoronary imaging, particularly with the OCT. IVUS is not so good as OCT in detecting the thickness of calcium and quantifying it, as we have listened. Recently, we have seen this data that have been mentioned during the live case in the European Heart Journal, a sub-analysis of the Illumin 4. So essentially, in the two groups of patients with moderate or severe calcification and those with no or mild calcification, the results of OCT versus angiography had a statistical interaction. So essentially, OCT was better than angiography in reducing target vessel failure at 2 years, only in the group of patients with moderate severe calcification. Of course, there is a lot of confounding here, but it makes a lot of sense, of course. So imaging is particularly helpful in this setting. But we have to discuss dedicated devices, and I think we have to start with the balloons. We have standard balloons, we have specialty balloons. Standard balloons in this setting are the high and super high pressure non-compliant balloons, which have high strength and radial force. The specialty balloons, cutting balloon, scoring balloons have blades, and these elements are embedded, and they concentrate the force locally and focally. So they are quite superior in superficial calcium. The standard balloon has some effect on the superficial calcium and are quite limited in the deep or nodular calcium as well. And of course, there are differences in terms of the risk of dissection and of course the deliverability. When we compare this kind of balloons head-to-head, we have some data that comes from the COPS trial, for example. The minimal stent area, which was the primary endpoint in this small study of 100 patients with more than 100 degrees of calcium by IVUS, shows that the cutting balloon was better than the non-compliant balloon with the P of superiority of 0.035. However, when you look at another study, which is the ISER calc, you don't see this benefit. When you compare super high pressure balloon, the OPN, versus the scoring balloon, there is essentially no difference in this small study of 74 patients with severely calcified lesions after unsuccessful lesion preparation. So the jury's out. Is not very clear whether one is prevailing over the other. Talking about atherectomy techniques, rotational and orbital, of course, the mechanism is a bit different. The rotating bar for rotational atherectomy, the eccentric crown for the orbital atherectomy. In terms of the calcium, you are able to ablate. Essentially, it's superficial for the rotational atherectomy, superficial to moderate in case you use the orbital atherectomy. And there are some differences, again, in terms of crossability, and the learning curve that is required by both is quite moderate, I would say. There are some trials of rotablator. I think the two most relevant are Rotaxis and Prepare Calc. Rotaxis had the primary endpoint of late luminal loss at 9 months, and it was better with the rotablator as compared with the no use of rotational atherectomy. In Prepare Calc, one of the co-primary endpoints was strategy success, which was better with rotational atherectomy as compared with specialty balloons. So there are some data that back up the use of rotational atherectomy, although of course these are small studies. And when you compare the rotational atherectomy with the orbital atherectomy, you find this small study that comes from Japan. The primary endpoint was stent expansion by OCT in 100 patients with calcified lesions or angiographically moderate to severe calcification, and it seems that rotational atherectomy was better than orbital atherectomy in this head-to-head comparison. So this is one of the reasons why maybe the ECLIPSE study didn't meet the primary endpoint. You see that the rotational atherectomy apparently was better. And we have seen these disappointing results of ECLIPSE, where the primary endpoint of target vessel failure in this very large study of more than 2,000 patients with severely calcified lesions amenable to both procedures, there was no difference in terms of the primary endpoint between orbital atherectomy and balloon angioplasty, and there was also no increase in the minimal stent area. So ECLIPSE, in brief, tell us a story which I think is relevant. Remember that the patients who were included in this study were amenable to both options. So these were not the patients that were only intended for a rotational atherectomy. There are patients that we will continue to use orbital atherectomy or rotational atherectomy, and they are not candidates for ballooning. So atherectomy, in this case, increased procedural complexity without improving outcomes in most severely calcified but balloon dilatable lesions. So if you can use a balloon, use a balloon. And it's also relevant that in this study there was a very low crossover rate, 4.9% to atherectomy or lithotripsy, which suggests that balloon-based preparation was sufficient in most of the cases, if not all of them. So finally, lithotripsy and laser. I think this is also quite relevant. I would say other modification devices. The mechanism for lithotripsy is sonic pressure waves. For laser, UV laser. The calcium type that is ablated or eliminated is superficial and deep. For lithotripsy, it's mostly superficial for a laser. I would say that the deliverability is an issue here because for lithotripsy, it's balloon-based, so it's moderate. For laser, it's excellent with small catheter profile. And of course, there is an issue of learning curve here as well, and also a different risk profile. This study that we have seen at the very beginning is comparing the three techniques. It's called roller coaster EPIC 22. Intravascular lithotripsy was similar to rotational atherectomy in terms of stent expansion by OCT, while ELCA, excimer laser atherectomy, was inferior in terms of stent expansion. So there is a kind of gradient in what you can achieve with these techniques. So finally, I would like to show the algorithm approach that perhaps you may keep in mind when it comes to selecting this technique, because there are many, and therefore they can generate some level of confusion. So I think the starting point is angiography, where you see moderate to severe calcification, like in this picture, and then you do intravascular imaging, or you try to do it. And of course, you may have these four situations: deep calcium, you may have superficial calcium, you may have a nodular calcium, or the device doesn't cross, which is something that may happen as well. So if the device doesn't cross, then this is the space for rotational atherectomy or orbital atherectomy in this order, and this is followed if you have it also by ELCA. If there is nodular calcium, then IVL is the way to go, followed by orbital atherectomy in preference to rotational atherectomy. In case of deep calcium, this is a good space to start with the non-compliant or specialty balloons, followed by intravascular lithotripsy. And in case of superficial calcium, then the next logical question is whether there are high-risk features. In particular, you can use these scores, the OCT score or the IVUS score with different rules. I will not go into the detail, but OCT score of 3 or IVUS score of 2 or more identify the high-risk characteristics in those who have a superficial calcium. So in case of yes, you go for intravascular lithotripsy. If there are no high-risk features, you go and you start with the balloons. Of course, please keep in mind the combination therapy. You can also combine these strategies, but this would deserve another, of course, talk by itself. So if you achieve a full non-compliant balloon expansion after all these techniques of debulking, calcium fracture or nodular debulking on OCT or IVUS, of course, you can implant the DES. In case that this is not achieved, then you can start again with this sequence of IVL, OPN, rotational atherectomy, orbital atherectomy. If you implanted the drug-eluting stent, of course, it's important to post-dilate and then do again intravascular imaging in order to see whether there is underexpansion. And in case of underexpansion, again, IVL, OPN, and rotational and orbital atherectomy. So in conclusion, I would say that calcified lesions are among the most challenging patient subsets for PCI. There is robust evidence for the available calcium modification tools. No, because it's definitely limited. And the ECLIPSE trial is probably the main exception because it was a large study, but we have seen the results. In stable patients with calcified lesions, medical therapy is often preferred, so we have also to remember that there is this option, and surgery may suit young patients with multivessel disease and calcified arteries. PCI is feasible in selected cases with careful planning, as we have seen, with data integration, and of course with the expert use of the available devices. Thank you.